Bismillah ar-Rahman ar-Rahim. It's a pleasure and an honor to be invited to join this very reputable meeting, the 19th International Thalassemia Day Conference. I thank very much my professor, Professor Dr. Amal Bishlawi, for giving me the opportunity to join in such a scientific meeting. And in this 8th session, which is about the pathogenesis of liver disease in multi-transfused patients, with a highlight on the HCV because of the new advances in HCV. I'm very happy to chair this session with Professor Mona Hamdi. And I'm introducing our first speaker, Professor Dimitrios Kountouras from Greece, and he's having a state-of-the-art lecture on hepatitis C in hemoglobinopathies. He's an internal medicine and hepatologist, and he says that in a few years he'll become a hematologist. Okay.
Depends on how often we meet. If we meet really often, then I can improve. I really can improve. I'd like to thank once again and many times that I have the chance to do so, Professor Beslavi, for this invitation. And I'd like to tell you that I really feel comfortable, I really feel nice, and I really feel happy to be in Cairo again. I have been here a few times more, and I will be coming again and again. This topic is very difficult to me because hepatitis C treatment, that is the trend these days, is changing very rapidly, and even the guidelines are changing with not always great changes, but really changing from time to time, from month to month. And I can say we are living in a Toy Story because we do not have in these days an incurable disease. Hepatitis C is the only one viral infection that can be totally eliminated with drugs, with simple drugs. This is the new era for this, and look where we are coming from ages where the viral response was really poor. And you can see here for genotype 1, with combination treatments that all of you have tried with your patients. And then the new era with the new drugs, the new substances that have changed the whole field. They have very different characteristics. They have nothing to do with the treatment strategies and nothing to do with the treatment mechanisms of the past. We do not use immunological treatment like interferon. We are using new drugs that are interfering with viral replication or assembly. These are the three categories. And the nice thing is how their names end in Previr, Pasvir, and Buvir, according to if they attack the relevant sites of the cycle of the virus, the NS34A protease inhibitor, the NS5A protein, and the NS5B site, which are responsible for different actions. The NS34 protease is like a scissor that, after the polyprotein is formated, the polyprotein of the virus, is cutting his pieces to form the parts that are going to act and prepare the new viral genome. And then there is a very important site for intervention, the NS5A place, where we can block replication of the complex for formation and assembly of the virus, and of course a very important site, the NS5B polymerase site, that is the backbone of all treatments. This is the heavy artillery of the new treatments. There's no treatment, no new treatment, no combination treatment, as all of new treatments are, that does not include this NS5B polymerase inhibitor. And here are the classes of investigational agents for treatment of chronic HCV, and we have actions in the entry, the replication, and the processing of the polyprotein and the assembly, and of course a few older host targets like miRNA and cyclophilin and the cyclophilin inhibitors. The new drugs approved from multiple classes basis of 216 combination HCV regimens are these, and this has been evolved to a really great armament of the new medicines. You can take a picture of this, but there's no need because you can find all these in the EASL guidelines in the Journal of Hepatology of 2018. You can see that these have not even been published in paper yet, but you can find them online. And this is the description of all regimens approved and used in Europe in 2018. And also there are many other drugs coming to help and fill up all this armament, and the trend is to have multiple combinations of drugs that will interfere, that will act in all three of the sites. So we have multiple drugs that are much different than what we used to do in the past. The basic characteristics of all the new treatments are that they are all oral, of short duration, 3 to 6 months, or even 8 weeks, only 2 months, the new regimens and the new combinations, with no serious adverse events. It's very rare the patient to discontinue treatment. With an SVR more than 90%, and this SVR, the sustained virological response, is independent of previous response. You very clearly remember how difficult it was to treat patients with previous failures with interferon. How many of your patients have been treated 3, 4, 5, 6 times, and you had failures and very, very bad side effects. They are suitable for all genotypes, and soon we will have 2 or 3, maybe not more, pan-genotypic medications, pan-genotypic drugs that will be suitable for any kind of genotype. There will be a moment that you will simply have hepatitis C, and you will take your pill, perhaps even from the pharmacy, and that's all. And they are suitable also for special patients groups. So where does HCV therapy stand now? Interferon is gone. Ribavirin is still useful. SVR is more than 95% of patients, and difficult to cure populations that are of major interest for us are no longer difficult. There is no difficult patient anymore. Black race, HIV co-infections, persons who inject drugs. Genotype 3 remains still more challenging, but the results are very good. And of course, thalassemic patients and patients with similar problems. And there are a few emerging issues like HBV reactivation and cost and access issues that persist but improving. We're going to evaluate a few of these topics. But to end with what we can do, I will try to pass this fast because this is not interesting anymore. You do have drugs, so the drugs you have are presented here. For genotype 1 without cirrhosis, you have all these choices which are almost equivalent in potency and viral response, and also few of them can be administered for only 8 weeks, minimizing the time and the cost of the treatment. And there are very slight differences between genotype 1A and genotype 1B, and you can see here that also ribavirin is still an important player for these treatments, and a few of these choices can be only in consideration with no baseline NS5A resistance-associated species. So let's go to patients with cirrhosis that were the very difficult part of treatment in the past. Even these patients for genotype 1, for genotype 1A and genotype 1B have their solutions, again in consideration of baseline NS5B for elbasvir and grazoprevir RAS detected, and we have to add in that cases ribavirin to the standard combinations that we are going to use. And also sometimes we have to adjust the duration of the treatment. So you can see how important it is to know in some cases if there are NS5A resistance associated. In that case, we must prolong the treatment from 12, not to 8, but to 16 weeks, or alternatively, we can add ribavirin, and of course, particularly for genotype 1A, we must have baseline sequencing to find out if RAS are there. And a few real-world data, as it is usually said, we can see here how elbasvir, grazoprevir, is acting in action in 3 different studies with excellent results, 97%, all of them. And what about these resistance considerations that I have expressed? Which classes are prone to resistance? Almost all of the classes, but not in the same intensity. You can see that mainly the older class of drugs, the protease inhibitors and the NS5A perform a resistance pattern that is higher to genotype 1B by genotype 1A. And most patients with failure of current DAAs have emergent resistance-associated substitutions, and NS5A persists much longer than PI RAS in the past. And 50% of the patients have baseline NS5A RAS with variable effects on genotype 1 response. Of course, we're expecting that second-generation drugs are designed to cover the resistance-associated species, and they will do that successfully. And the treatment for the real hard guy of our times, it's not genotype 1, not genotype 4, as we are used to believe. In our times, the hard guy is genotype 3, and this resistance profile for this virus probably has to do with genomic characteristics or the fat accumulation that this genotype presents, or even the duration or the route of infection that is mainly from persons injecting drugs. And when there is cirrhosis, then in these patients we must do testing for the resistance-associated species, and this is how we design and how we decide what their treatments will be. And for experienced patients with genotype 3, we do not test if they do not have cirrhosis. We test those that we test those that do not have cirrhosis, not those who have. Probably because in the past the interferons have cleared out a part of patients with that profile, and we need this testing for in purpose to use elbasvir or grazoprevir for treatment. And what about for ribavirin? There is a need for ribavirin still when baseline resistant species are there, and for patients with both cirrhosis and previous combination treatment, ribavirin is required regardless of Y93 status, unless using elbasvir, grazoprevir, and sofosbuvir that really will need to check if RAVs are there, and then we must prolong treatment. Recommended regimens for treatment-naive patients with genotype 2, 4, 5, and 6. You see that I mentioned nothing for genotype 2 that is more than easy in our days, and you see that in total all these easy to cure genotypes can have the same treatment response either for cirrhotics or not cirrhotic patients, and we have a lot of choices that are equal to results, to sustained virological response. And for experienced patients with these genotypes, we have almost the same results and then the same choices for treatment. And it is only for the dipasvir-sofosbuvir combination that in compensated cirrhosis we must add ribavirin. You do not have to really remember these by heart. They are very clearly defined. You just roll down the patient's prepositions for treatment and decide. But do direct antivirals increase the risk of de novo or recurrent hepatocellular carcinoma? This is a very, very new question. And it is not that far, it is not that remote from daily practice. And I will show you, following to my talk, what I really mean with this. Because we had to deal with patients with hepatocellular carcinoma. And it was hypothesized that there is a higher rate of hepatocellular carcinoma recurrence with DAAs, and there are a few studies for this. And the question was, does it happen among patients starting DAAs less than 4 months or after treatment, and what are the differences? Is this de novo hepatocellular carcinoma provoked by the treatment, or is it there and then the treatment overlaps with its existence? And it seems that hepatocellular carcinoma occurrence or recurrence is equivalent in patients with SVR to DAAs vice interferon. And I would like to remind you that we felt that interferon could probably delay the appearance of hepatocellular carcinoma, but things seem not to be so, because in the end probably the virus is not the main cause for all this trouble. So de novo hepatocellular carcinoma in HCV infected patients treated with oral DAAs seem to be a little higher in patients with cirrhosis and advanced cirrhosis with Child-Pugh score B. But in the end, there is no real difference in the incidence, and only in the cirrhotics with high score of high Child-Pugh score you can see this to happen. But this is almost normal. It is almost expected for patients with end-stage cirrhosis. And this can be clearly seen. I'd like to underline these elements here, that the upper score was higher for patients that developed hepatocellular carcinoma and SVR, and these patients had not succeeded in achieving SVR. So there are harder patients in the end stage of their disease. So cirrhotic patients with hepatitis C treated with DAAs are not really at increased risk of developing hepatocellular carcinoma compared with untreated patients, but probably we have a lot of things to see in the future, and it's a very interesting consideration to have in mind and expect more clues for what we're worrying about. And what about hepatitis B reactivation during treatment with DAAs? There are case reports for reactivation in patients treated with older treatments, probably because we do not have the new series of patients treated with the new ones, because it's not the class of antivirals, it is the stage after treatment that we expect this. And there are 29 confirmed cases of HBV reactivation in patients that were treated with DAAs. And most cases occurred within 4 to 8 weeks with HCV DAA initiation. And this is the reason why we should test all patients initiating hepatitis C treatment for HBs antigen, anti-HB core, and anti-HBsO to have the full panel of their HBV history before we start. And the reason is that after elimination of hepatitis C, we have a change in the immunological status, and then the so far suppressed hepatitis B can reactivate and start infecting again the liver. Here are the treatment recommendations in general. I only present these to show that you can find any detail that you might need for each one person, for each one patient, and you can see that there are no real differences between patients with cirrhosis or not cirrhosis, or patients co-infected with hepatitis, with HIV. But the important thing is to notice here that we have some interesting and dangerous drug interactions between hepatitis C drugs and cardiovascular medication mainly, and this is of great importance for our patients that are also almost a lot of them cardiological patients due to cardiac insufficiency because of the iron toxicity. So we must be very careful how to choose their choices, and there are rules and there are applications to help and prepare their treatment the right way so that not to make them get into danger. There are no absolute contraindications for these medications, except for that sofosbuvir should be used with caution in patients with severe renal impairments. So the renal function is another one thing that we must be sure how well works in our patient. And it is also contraindicated in patients receiving amiodarone who cannot switch to another therapy. Also treatment regimens comprising an NS3/4A protease inhibitor, such as the older ones, imepravir, and ritonavir boosted paritapravir or grazopravir, should not be used in combination. And what about patients with compensated cirrhosis but without previous episodes of decompensation? These patients can be very carefully treated, and they must avoid the protease inhibitors if possible because of the substantially higher protease inhibitor concentration in these patients. They must avoid this class of medication. And what about ribavirin? That was a nightmare in the past when you had to combine this with interferon. Hemoglobin levels should be carefully and frequently monitored, and ribavirin administration should be interrupted in case of severe anemia with hemoglobin less than 8.5 grams per deciliter, and the use of erythropoietin and eventually blood transfusion may be useful in patients with severe ribavirin-induced anemia, but it simply doesn't ever happen. I'm sure that if we discuss later, a lot of you will have an excellent experience with the new behavior of ribavirin when she doesn't have to be comprised with interferon. And patients with cirrhosis and those with contraindication or who do not tolerate ribavirin may benefit from 24 weeks of these therapies without ribavirin, or 16 weeks instead of taking the medication if this is not safe. So in conclusion, multiple current regimens are highly effective and safe across genotypes confirmed in real-world studies. Glecaprevir and Prepitazvir appears poised to an 8-week pangenotypic regimen for DAA naive non-cirrhotic patients. So you are expecting, as I said, the pangenotypic medications that will do all the job very simply. Short duration, not superior to current regimen for DAA naive patients. We also expect other pangenotypic regimens and their action in real life. And there's a controversy about HCC recurrence after SVR, but we have in mind that it's not really clear at the moment. And HBV activation, it's very rare in anti-HB core positive patients, and precautions in HBs antigen positive patients, especially with HBV viremia, should be taken care. And what about treatment hemoglobinopathies? It's as simple as this. There is no real difference, and the indications for hepatitis C therapy are exactly the same in patients with and without hemoglobinopathies or bleeding disorders, and interferon-free, ribavirin-free anti-HCV regimens that can be used in patients with hemoglobinopathies or bleeding disorders are the same as in patients without hemoglobinopathies or bleeding disorders. But what is the true story? This is the story, the toy story, how nice, how playful these new drugs are. But what is our story? The story of hepatitis C in patients with thalassemia. And also, I'd like to say that it is a game of true tales told to friends, because friends are all these people, all of you, that have fighted with your patients for 20 or 30 years, and hepatitis C from its starting until today. These are the true friends that can understand our agony when all these studies that you can see here with different ages of patients, different regimens, different durations, that in the end gave very poor SVR results and very high dropout rate. Look here for 57.1%. And when we added interferon, ribavirin, we obtained the SVR we wanted, but in a very high cost in transfusion requirements and all the complications of this. Is this the time to discuss how much we need these treatments? They are there, they are easy to use, and they are very potent, and they are very safe. But how much do we really need them now? How high is the emergency to oppress the regulatory agents in a country to have more financing of this and have more opportunities for treatment? How eager should we be? You can see here how the hepatitis C history is actually. It needs almost 30 years to get to cirrhosis, and then 6 to 8% every year to present with hepatocellular carcinoma or to deviate to decompensation. All of our patients, most of our patients now, are at an age of 40 and 50, but we actually do not have patients with decompensated cirrhosis, but patients that are going through and straight to developing hepatocellular carcinoma. And we clearly know that in patients with chronic hepatitis C and established cirrhosis, there's an incidence of hepatocellular carcinoma at a rate of 2 to 8% per year. So we are not inside the expected rate of cirrhosis, but we are approaching the unexpected rate of the emergence of hepatocellular carcinoma that, as we talked also yesterday, probably should be attributed to not to hepatitis C, but to iron. And here you have a few discussion to do. And you can see here the classical papers that were debating between liver disease with or without hepatitis C infection, and they had a misleading message that hepatitis C really makes the difference. But if you have a closer look, you can see that there is in reality an age-related progress of the disease. And moreover, when you go to another older and classical paper about fibrosis progression-free survival, you can see that again, it is low iron and high iron that define the range, the limit of pathology, and it's higher transfusion frequency probably, and higher frequency through this of HCV infection that makes us believe in the impression of hepatitis C interference. Problem with the time? Oh, sorry. So, you can see that these patients actually are the same or even better than the general population, and we have low viremia, low inflammation, and no fibrosis developing rate. And the natural history in many other studies, you can see that is confirmed that it's hepatitis, not hepatitis C, but iron that makes the difference, and even patients that have been treated in the past do not have a better fibrosis score than the others. And then we have studies, real-life studies, that comparison of response with interference cannot stand against the new treatment standards with an SVR of 100%, and also another study of ours where you can see how great things are. And here is the Elbasville Grassopavir, the CH study, where we had again excellent results for all patients, but in consideration of NS5A resistance. And I will end presenting you a very small part of one of our studies, where I have to point out a few things, a few last things. Here you can see that we have transaminases after the end of treatment, and after SVR is achieved, we have transaminases lower than what is normally expected as normal, which means that really there is a minimal inflammation that is attributed, that should be attributed to hepatitis C, that is eliminated after treatment. We do not really know how much that will confer in better fibrosis scores in the future, and what that will mean for hepatocellular carcinoma, but this is something that we must keep in mind. All these results are conferring the same nice information, except for these 3 patients out of 5 that did not respond to treatment, that had underlying hepatocellular carcinoma. They had already hepatocellular carcinoma, it didn't respond well. This means that probably the virus is nesting more comfortably inside hepatocellular carcinoma cells than what in the rest of the liver, and this is sometimes it could be an index of underlying treatment, underlying disease. So questions for the future. I'm finishing, Mr. President. Mrs. President. The normal limits of transaminases for this patient group without hemochromatosis and normal LIC. What these will be without hepatitis C or after HCV is eliminated, and what is the real role of minimal inflammation represented by elevated transaminases within the normal range and associated with the presence of hepatitis C for the process of fibrosis. Another question is the future benefit of fibrosis from this apparent biochemical response, the role of hepatocellular carcinoma in treatment failures, and the emergence of hepatocellular carcinoma after DAAs treatments. And the new guidelines are only interferon-free treatments, indications and efficacy of treatment are the same, careful choice and decision on the duration of treatments, hemochromatosis and chelation makes no difference in therapy choice, priority for treatment should be the same as for patients with comorbidities, ribavirin can be used safely, and caution for drug-drug interaction is needed. So there's no black and not white yet. Try to explore that gray future, and things will be always right. Thank you.